And there is a little bit of a lag while we watch them come in, so that'll just give us time. If this is your dance studio, Dr. Farkas, feel free.
No, I'm good. I just kind of feel like I'm gonna have to talk fast because this time limit is rough.
What is the temperature up there? Do you have one of those like mini splits up there?
Who, me? No,
Yeah.
this is actually fully air conditioned and heated.
Oh, I love it.
Lovely.
Yeah, this was part of the renovation. This is Jacob's place. It's not really mine. So all the stuff behind you is kind of like his paraphernalia.
I do
Okay,
love
why
that
don't you tell us about
triangle
it? No, I'm
though.
kidding.
It's
Hmm?
great.
I said you can
Yeah,
tell us about it. No, I'm kidding.
I make him hide up here. It's like his
There's so
at
many people that do like podcasts. They have like their stuff behind them and stuff. Like my office upstairs is just kind of like, so
well,
I
I like
decided
that
to
piece
do
of art
one.
that's behind you. It's
This
kind of
is in
cool.
the dining room. Yeah, that's a piece of art from the Elizabeth, or from the, yeah, it's from the Artisan Works.
Oh,
Oh, I love
Oh,
that
I forget
cool.
the
place.
artist. It
Hey,
is, you can
that's
put
where
like
we're going to
little
be for
things inside of a
October this
little,
year.
you can
I
put like little things
heard.
inside each thing.
Wonderful.
I'm just
Yeah.
gonna nominate myself this year. I want to be the MC. I don't want to
You're
know
going to have
words.
to duke out Deanna Dewberry for that.
Girl, I could take her down. I don't
Oh,
know. This is
wow.
getting
This
off
is
to
going in a
quite.
totally different direction than I expected tonight. All
Steve's like,
right.
I
Well,
don't know what you're
let's.
saying now. I'm not okay with it.
Oh my gosh. All right. Well, let's get started here.
Ready,
As
ready.
folks are joining us, I'm Christina Thompson, Executive Director of the Breast Cancer Coalition. We're so glad that you're joining us for this important program made possible in part by the Lee C. Rosenthal Memorial Education Fund. Our webinar series is designed to inform, empower, and connect individuals impacted by breast or gynecologic cancers, ensuring that you have access to the latest insights from experts in the field. So just a couple of housekeeping notes. This is being recorded and it will be available on our website tomorrow for your review. Closed captions can be accessed using the button at the bottom of your screen in the middle. Slides for Dr. Farkas's presentation were sent out an hour ago. Maybe Rachel can help me out and put that in the chat for folks who need to access that. A survey will pop up in your browser at any point that you leave the webinar tonight. Please take a minute to provide feedback. We truly appreciate the opportunity to learn what programs and offerings are most relevant to our community. Please enter questions for Dr. Farkas or Dr. Vega in the chat, and Rachel Rosen-Simpson, the Coalition's program manager, will facilitate a Q&A session following the presentations. Just as one note, the doctors won't speak to specific cases, so please keep your questions general. We do have a couple of really exciting announcements. So it is time to nominate your oncology provider for the Heart and Hands Award. This is an annual award given by the Breast Cancer Coalition. Eligible providers include doctors, primary care physicians, oncologists, radiologists, NPs, social workers, the whole gamut of folks that you encounter during your treatment for breast cancer. And really, we're looking for people who showed kindness and compassion, collaboration, respect, clinical excellence. And I will drop the link for where you can submit that nomination in the chat as well. We'd love to hear from you if your provider made a difference in your care. We're also excited that the Pink and Teal Challenge for the Coalition, our largest fundraiser, is coming soon on Saturday, May 10th at Monroe Community College. You can join now to walk, run, or volunteer. And just know that your participation helps support our mission to provide education, support, and advocacy for those impacted in our community. So thanks for being a part of the seminar tonight, and let's get started. We are honored to welcome Dr. Stephen Vega and Dr. Rachel Farkas, two leading experts in breast cancer surgery and reconstruction. Dr. Stephen Vega is a board-certified plastic surgeon specializing in advanced breast reconstruction techniques. With extensive training in microsurgery and a commitment to innovation, he continues to refine surgical approaches that improve outcomes and enhance patient care. Dr. Rachel Farkas is a highly respected surgical oncologist with over 12 years of experience in breast cancer surgery. She specializes in mastectomy techniques, hidden scar breast surgery, and lymph node procedures, providing expert care for both breast cancer patients and those at high risk. So together, this is what is really unique about these two. Dr. Vega and Dr. Farkas bring a collaborative approach to surgery, ensuring patients receive the highest level of precision, innovation, and compassionate care. And so with that, Dr. Farkas, would you like to take it away?
I would. Am I sharing already?
Not yet.
Oh, let me share then.
Let's walk through that.
I'm good, I think.
Oh, looks great. Go
All
for
right.
it.
Great. So thank you so much, everybody, and good evening. Thank you for the invitation to speak to all of you tonight about the surgical management of breast cancer. It really is a pleasure and a privilege to spend some time with you, and I hope that each of you will be able to take away a few pearls about this important topic. Now, because the topic of surgical management of breast cancer is extremely broad, I chose to narrow my focus tonight on an aspect of breast cancer surgery that doesn't always receive sufficient attention. How can we optimally treat cancer while still preserving the form and function of the breast? There are many ways to minimize negative cosmetic impact on the breast with breast cancer surgery. And when I think about it, I think I can even go a step further and say, can we come up with a treatment plan that treats a new cancer or an existing cancer and give the patient improved cosmesis in whatever way she interprets that? So let's get started. And so again, the goal is to optimally treat breast cancer while preserving form and function. So just, there are no disclaimers, but a quick message. All of the patient images in this presentation were taken in our office. And this presentation would not be possible without the generosity of our patients sharing their very intimate images. Permission was obtained from all the patients whose images are included in this presentation, and we just ask that you don't screenshot, reuse, or duplicate any of the images that you see in this presentation or Dr. Vega's presentation for any other purpose. So when we're talking about preserving form and function, I thought about 6 topics that really sort of epitomize it. So we want to minimize treatment when possible. We want to optimize sequence of treatment, whether that's surgery, chemotherapy, or radiation. We want to preserve the breast when at all possible. We want to optimize our incision choices for lumpectomy and mastectomy. I want to touch upon risk-reducing surgery and then also multidisciplinary surgical care. So your breast, I know everyone knows this face. Your breast surgeon should be the quarterback of your breast cancer treatment team. The breast surgeon is often the first face that you meet, and that person should be coordinating all of your other care, contacting other doctors, communicating with them, and making sure that your treatment plan is seamless. So what can you expect from a new patient visit with a breast cancer surgeon? Well, you need an explanation of the natural history of breast cancer, a full description of the workup, which often includes mammogram, ultrasound, and sometimes MRI, a review of the pathology report, a recommendation for additional testing or imaging if some has not been done, and then a review of your surgical options. So most of us are visual learners. And for those of you who attended my talk previously, you know that I like to use this image, but I can't give a talk without it. So when the natural history of breast cancer is explained to you at your first consultation, I like to draw it out in this image. If you look at the image, you have the square nipple at the top and the milk ducts extending down to the bottom of the page. At the end of the ducts are the lobules. And then where you see the little circles filling in that duct, those are cancer cells. Cancer cells start within the duct. And when they start within the duct, that is called DCIS. DCIS is stage 0 disease because stage is really an indication of how worried we are that the cancer has spread. So with stage 0 disease, we're not worried about spread, but we know the cancer has to be removed. If you see the arrow pointing out of that milk duct where the cancer cells are now outside of the duct, the cancer cells have invaded into the fat of the breast tissue. They can be either ductal or lobular. And so we get the phrase, for instance, invasive ductal cancer. That starts at stage 1 and can extend based on the size of the tumor or lymph node involvement. We know that breast cancer spreads to the lymph nodes when it's trying to get out of the breast. The lymph nodes are kind of like the air conditioner filter. They basically capture cells that are in transit. And then once the lymph nodes have cancer in them, there's always the possibility that breast cancer can spread to other parts of the body. That is stage 4. In the top left corner of the image, you can see that there is a differentiation between ductal and lobular cancer. We know most breast cancers are ductal, 80%, and they grow in a mass-forming fashion where cells tack onto one another, so they're easier to be seen on imaging. Lobular cancer, which is the less common form, tends to grow like tentacles of an octopus. The cancer cells fan out, and so they're not as easily detected on imaging in an early stage. When you meet with a surgeon, you should go through all of the imaging that has been done thus far. This is just an example of how I go through imaging in the office. It documents all of the workup that has been done thus far, including the mammogram. I don't think I have a pointer, but you can see there's a whitish density in the sort of lateral part of the image, the ultrasound, the post-clip mammogram, where there is a very, very small titanium marker that marks where the biopsy was done, and this image will be a bit easier, the MRI. We know that MRI is a really sensitive test for breast cancer, but you can see yourself that the cancer is really well delineated in MRI because MRI shows us areas of increased blood flow, and we know that cancer, as it is more metabolically active, will show us a three-dimensional view on the MRI. Once you understand the natural history of breast cancer, we can go through an algorithm of how to decide what surgery is best for you. The first thing I always think of is, was genetic testing done or should it be done? We know that women who carry a genetic mutation or an actionable genetic mutation should be allowed to consider bilateral mastectomy, removal of both breasts, in an effort to reduce risk of a future cancer. We know that risk reduction is not complete, and therefore there is still some risk, approximately 5%, of developing cancer even after mastectomy. If you go to the other arm of the algorithm, if the genetic testing is negative, then a woman has a choice to choose lumpectomy, removal of the tumor with a rim of normal tissue around it, or mastectomy, removal of the entire breast. We know that whether you choose lumpectomy or mastectomy, women have equivalent overall survival. So I always tell patients, you don't buy more survival points by having a mastectomy. We know that lumpectomy is usually paired with radiation treatment, and it has a small chance of re-excision, meaning needing to go back and take out more breast tissue if the margin is incomplete, if the cancer extends to the edge of the specimen that was removed. On the mastectomy arm, anytime we remove the breast, we always offer reconstruction. Reconstruction is done by our plastic surgeon with implant-based reconstruction or tissue reconstruction. And then what most women or what we're talking about now is also flat closure. And we'll go into that a little bit further, but flat closure can be performed by your breast surgeon. It is where the skin is brought together and you leave a flat contour to the chest. So in 2025, breast cancer treatment really should be tailored to the individual. Now, I know there's a lot of boxes here and I apologize, but there are many variables that go into a surgical plan. Size of tumor, size of breast, patient's age, hormone receptors, lymph node status. Will there be a need for chemotherapy or radiation? Was genetic testing done? Is there a mutation? What are the person's home or work responsibilities and financial considerations? All of these things really do factor in to the surgical plan. And ultimately, we know that it is the patient's choice. We have, more than one option, and all options are extended to the patient if they are feasible. So how can surgery be minimized? Well, I'm going to talk about how surgery can be minimized in the breast as well as the axilla. We just mentioned lumpectomy. We know the combination of lumpectomy and radiation is what is called breast conserving or breast conservation therapy. Lumpectomy is best for a small tumor in a larger breast, so the volume loss is not noticed. It's day surgery with minimal postoperative pain, often can be performed opioid-free, which most patients enjoy. There are minimal restrictions after surgery. It preserves both the sensation in the skin of the breast and the function of the breast, meaning sensation of the nipple. And return to work and life can happen in just a few days. Similarly, we can minimize axillary surgery and therefore minimize lymphedema. We know that the lymphatics that supply the breast and the arm cross in the armpit. And so anytime we perform axillary surgery, we open up to the risk of lymphedema. For a woman who is node negative, meaning she does not have disease that is seen in her lymph nodes, a sentinel lymph node is usually performed, which is a selective sampling of 1 or 2 lymph nodes with a 2 to 5% risk of lymphedema, usually on the lower end. But when a woman presents with lymph node disease after her biopsy, the recommended treatment is a full lymph node dissection, removal of the bulk of the lymph nodes underneath the arm, and that carries with it a 30 to 50% risk of lymphedema. And that number is considerably higher also because that usually involves radiation treatment. You can see on the right side of the picture, lymphedema can be subtle, where the hand is just a little bit swollen, or it can be really debilitating and painful. So in which patients can we omit the sentinel node biopsy? Well, the Choosing Wisely criteria that actually came out in 2016, so that is a while back, let us know that in women who are over age 70, who are clinically node negative, so do not have lymph node disease on presentation, who have early stage disease, T1 and T2, and are hormone receptor positive, that means ER positive and HER2 negative, they can safely omit the sentinel node biopsy. And the reason is because even if the lymph node is removed, and even if there is some cancer in it, it will not change the treatment algorithm and will not change the patient's survival. Now, can we figure out how treatment sequence can affect surgery? So we also know that primary chemotherapy, which is chemotherapy before surgery, can be used to downstage a primary tumor. If you're looking at these images, you may not notice the mass, but if I put some pink color onto it, you can see the mass in the upper image is considerably larger. And then after chemotherapy, the image on the bottom of the screen, the tumor is much smaller. Primary chemotherapy can shrink the tumor, sometimes can eliminate the tumor in total, and that can allow for breast conserving therapy, right? A woman who thought she may need a mastectomy for a large tumor can now have a lumpectomy, or maybe a more cosmetic mastectomy incision if the tumor pulls away from the overlying skin. We can also use chemotherapy to downstage the axilla, and by that I mean if a patient is diagnosed with breast cancer in her lymph nodes, standard of care treatment, as I said, is a complete lymph node removal, which is removal of the bulk of the lymph nodes under the arm, high risk of lymphedema. If she chooses to have chemotherapy before surgery and the lymph nodes shrink back to normal size and shape on the imaging after chemotherapy, a sentinel node biopsy can be performed. Again, this allows for a smaller surgery, an easier recovery, and less risk of lymphedema. And then briefly, we can also talk about opportunities to minimize or omit radiation. We all know that the standard treatment, whole breast radiation, 5 days a week for 6 to 7 weeks, usually a total of 35 treatments. But now many of our patients are being offered partial breast radiation, which is a shorter course, 2 to 4 weeks, less disruptive, less cost, less radiation dose, with equivalent outcomes. So it's not that we're doing less and expecting less, but we're doing less and expecting the same outcomes, often with improved cosmesis because there's less dose of radiation. There are courses of radiation offered in our community now that are every other day. So if there are skin toxicities, treatment can be done every other day with improved cosmesis and less skin damage. And there are also trials that are ongoing in our community that allow women to avoid radiation if they continue on an aromatase inhibitor for 5 years. Now, before you get excited about that, because most people would love to omit radiation, that does have a certain inclusion criteria, but I recommend that if you're considering that, to inquire with your radiation oncologist. Now, how can we preserve breast form in breast conservation? So I would call this a traditional lumpectomy. This is a lumpectomy where a large volume of tumor was removed, or maybe not, but a large volume of breast tissue was removed, and the patient is left with a considerable asymmetry. This is a traditional lumpectomy closure. So if the breast tissue and tumor is removed and we don't pay careful attention to how we close the lumpectomy, you can end up with this puckering and divoting, which really leaves a poor cosmetic result in the breast. And so now when we approach lumpectomy, the first thought is, can we do this with hidden scar surgery? Can we use a scar that we can hide in a natural crease or in a color change on the breast? So a periareolar incision is a scar that's placed around the edge of the areola, or maybe an incision in the inframammary fold, which is underneath the breast where the breast falls over, or maybe just a lateral incision that is not immediately seen on the face of the breast. So I would call this an example of hidden scar surgery. I think that the volume that this patient is left with after lumpectomy is pretty even. That's what you can see on the left side. And on the right side, we're zoomed in, and you may think that that mole that she had removed is her lumpectomy, but actually, oops, sorry about that. Do you see an arrow? Because I can't tell. No arrow? Oh, thank you. All right, so you see the arrow with the periareolar incision. Sorry, our face boxes are covering some of these slides. I apologize. Now, this is a lateral incision. So this patient did lose some volume, and she was okay with the volume loss in her breast, but was happy to see that her incision was placed carefully on the side of her breast. So it's not something that she sees in the mirror when she undresses. And finally, a medial incision. So sometimes we really do have to direct the incision right over the tumor, and this patient had a lesion that was in the inner part of her breast. But when you pay careful attention to close the defect in a way where it's not going to pucker, the patient has a pretty nice contour to her breast and is okay with a faded scar that can easily be seen. There are a variety of oncoplastic incisions. These are incisions that are used not only to make a favorable incision, but maybe also to lift or adjust the breast as needed. And all of these can be used to create a more cosmetic result. But what if a large volume of breast tissue needs to be removed? How can we restore balance after lumpectomy or after a unilateral mastectomy? Well, that is called a balancing procedure. And disclaimer, this is done with Dr. Vega. So in a patient who requires a large lumpectomy but has a medium to large size breast, what can be done is a breast reduction that is performed before radiation. So let me explain. This patient has a large ptotic breast, meaning low hanging, and had a large volume of breast tissue that needed to be removed. She didn't want to have a lumpectomy. She really, always wanted to have a breast reduction. And so Dr. Vega mapped out the incisions that he would use for his breast reduction. I worked within those incisions to do her lumpectomy. May not be easy to see from this image, but she did lose a considerable volume of breast tissue. And this is an image 2.5 years later after lumpectomy, balancing procedure, which was a breast reduction, and radiation. And she is very happy. Now, if the asymmetry is noted after completion of radiation, the contralateral or non-affected breast can be lifted to match the breast that was treated with surgery and radiation. So this patient underwent lumpectomy. She actually had 2 lumpectomies and had an asymmetry of her breast that bothered her. And so she, after completion of radiation, about a year later, underwent a balancing procedure with lifting of her opposite breast to create symmetry. Now, sometimes patients really want to have lumpectomy, but it doesn't work out. So this patient underwent lumpectomy. You can see the incision on her left breast over the areola. She actually had 2 lumpectomies. She lost a considerable volume of breast tissue and still had a positive margin. So we performed a nipple sparing mastectomy for her. Yes, you can tell that she did not have an immediate reconstruction, but that's still okay, because when you look at her final result that's on the right, she ended up with a beautiful implant reconstruction and a balancing procedure on the opposite side to create symmetry. But not all cancers can be treated with breast conservation. Sometimes the tumor is too big in a small breast. There are multiple lesions that are not amenable to multiple lumpectomy. Genetic abnormalities, strong family history of breast cancer, someone who, for medical reasons, cannot have radiation but desire symmetry, they choose to have a mastectomy. Now, with a mastectomy, it's important to know, because this question is asked a lot, the sensation that is lost is all of the sensation on the skin of that overlies the breast tissue. So from the collarbone to the fold, to inframammary fold, and from the sternum, which is the breastbone, to the mid armpit line. The other thing that's lost with mastectomy is the sensation in the nipple and areola. So whether you save the nipple areola or you don't save it, that sexual sensation is lost with a mastectomy. Mastectomy can be done in many different approaches, and really these different approaches are focused on how much skin is left. So with a total mastectomy, traditionally, the nipple and areola are removed and the volume of breast tissue along with enough skin to create a cosmetic closure. Now, this concept of aesthetic flat closure, I'm sure many of you have heard about it, is a little bit new. It's new to the NCCN or the National Cancer Guidelines, but it's something that breast surgeons have been doing for many years. We've been doing for many years, which is basically closing the skin flat. And closing the skin flat is not just an aesthetic consideration, but also important for women who choose to wear a prosthesis. I'm told that it is exceedingly uncomfortable to wear a prosthesis over redundant skin. So this is a patient who I met after she underwent her cancer care mastectomy on the left side with a balancing procedure on the right. This was done elsewhere. And she was very unhappy with her reconstruction. She asked to have bilateral mastectomy with a flat closure, and you can see her result on the other side, and she is very happy with this result. This patient underwent lumpectomy. You can see the vertical incision on her breast and had a cancer recurrence. With the cancer recurrence, she chose to have mastectomy. And you can see on the opposite side, her flat closure, which again, she is very happy with. And then this is one of the most satisfying types of patients that come to our office. It's a patient who underwent mastectomy, again, somewhere a little bit far out. And she was really unhappy with the redundant skin she had after mastectomy. I'm not sure it projects well, but she had redundant skin under her arms, which chafed every time she moved her arms. And she was really upset with the mass or the mound of tissue that she had in between her mastectomy scars. She called that her third breast or her new breast. And so she actually specifically came with the list of flat closures and asked for this single incision, and she wanted it flattened out across her chest so she would no longer chafe in the underarm and have that middle bulge removed. And flat closure is not limited to bilateral mastectomy. Patients who have a unilateral or one-sided mastectomy will often ask for a flat closure, again, in particular, so that they can wear a prosthesis comfortably against a flat chest wall. And this picture is pretty famous in BCCR. I know we're not in person, but they do have it hanging on the wall. So some of our patients do choose to have tattooing after a flat closure. These are not pictures from our office. They're off the internet, but I do think they're very beautiful, and it's a very creative way to cover scars. Now, if we pivot a little bit to a skin-sparing mastectomy, traditionally a skin-sparing mastectomy removes the nipple areolar complex, but preserves the rest of the mastectomy skin for a more natural-looking reconstruction. It also allows us to remove skin overlying a tumor, which sometimes is necessary if the tumor comes close to the underlying skin. So this patient had a cancer that was located just below her nipple areolar complex. She underwent mastectomy with vertical incisions, and this is her final implant reconstruction. But most of our skin-sparing mastectomies, the ones that Dr. Vega and I do together, are done through what's called wise pattern incisions. And these are two examples of wise pattern incisions. They basically look like an anchor. They remove the nipple areolar complex and the skin underneath. And I think Dr. Vega will talk a little bit more about that. So this is a patient who had a cancer and desired bilateral mastectomy. She underwent skin sparing mastectomy with this WISE pattern. You can see the vertical, oh, I do have an arrow. You can see the vertical part of her incision here, and the anchor or the underneath part is hidden in the fold of her breast. Another example, you can see this patient who had a biopsy in her left breast. She underwent bilateral mastectomy with tissue expander placement. So the image, I apologize, a little fuzzy on the right, are tissue expanders. This is her final implant reconstruction, and this is after nipple reconstruction and tattooing. Again, a way of preserving form is not only preserving the form of the breast as the patient had before, but preserving a form that looks natural and makes her feel more feminine. So finally, nipple sparing mastectomy preserves form, preserves the nipple and areolar skin. It can only be performed in patients who do not have a tumor that's close to the undersurface of the nipple or areola. The nipple must be in a reasonable position, which means it can't be really pointing too low, because that won't allow for a nice reconstruction with a good nipple position. We know, again, there will be no sensation in the mastectomy skin, no sensation, sexual sensation in the nipple, but interestingly enough, the nipple does react to cold. So this is a patient who underwent bilateral mastectomy with incisions underneath the breast, the inframammary fold, and you can see that this is her final cosmetic result. Another patient with inframammary fold incisions. When you look at this image, you can see that the nipple, what I was sort of referring to in terms of good anatomic position is the nipples are facing forward, and therefore she ends up with a good position for her nipple with her reconstruction. In these images, this patient had a little bit of a downward turning nipple, and so Dr. Vega mapped out these periareolar incisions, which removed the skin in between the black marking. This allowed to lift the nipple position and create a better result for her. And so I just want to touch on risk-reducing surgery, also known as prophylactic mastectomy. I like to think of it as risk-reducing, again, because it doesn't reduce the risk to zero. So some pearls of wisdom: you should never feel rushed, or no one should feel rushed heading into risk-reducing surgery. There should be a full surgical plan in place for the mastectomy and also for the reconstruction or closure, whatever is desired. Incisions should be thoughtfully placed. Hidden scars should always be considered. And a mastopexy, or a breast lift, can be performed to allow for nipple preservation. And I'll show you some images of that in a moment. MRI imaging should be done approximately 4 to 6 weeks prior to surgery so that we don't miss an abnormality. And if something is detected on imaging, it can be biopsied prior to surgery. So this patient underwent nipple sparing mastectomy with incisions above the areola. I think that projects well. And this is her final cosmetic result. Again, with a preventative or prophylactic surgery, we like to create something that is as natural as possible. This patient had nipples that are a little bit downward facing. You can tell that the distance from her collarbone to her nipple is a little bit prolonged. And so she wanted to save her nipples and underwent a mastopexy, or a breast lift, to move the nipples into a better position. Then by choice, she underwent nipple sparing mastectomy without immediate reconstruction. Again, she had some things going on in her life and really didn't want to do the reconstruction immediately, had her tissue expanders placed a couple of months later, and then her final reconstruction with implants. And just to drive the point home one more time is that a delayed reconstruction, lots of our patients will come to the office and say, I just need it all done at one time. I need it all. I need it done as quickly as possible. But sometimes a delayed reconstruction can really help with the nipple position. So, this patient underwent nipple sparing mastectomy with a delayed reconstruction and has a beautiful cosmetic result. There's absolutely no need to rush from the mastectomy to the reconstruction. Obviously, when it's possible, we do try to do it, but even if it's not possible, the outcomes are fantastic. We cannot talk about breast cancer treatment without talking about multidisciplinary care. That is the combination of your surgical oncologist, your medical oncologist who prescribes chemotherapy and hormone therapy, and your radiation oncologists. And that team really does extend to the physical therapists and occupational therapists and genetic counselors, but I would say this is your core team. But instead of multidisciplinary care, I'd like to shift your focus to multidisciplinary surgical care. So I would say that when you're looking at having mastectomy with reconstruction, mastectomy with a balancing procedure, or any of the things that we offer at our office, you really want to have two surgeons who are part of a team. You want two surgeons who respect one another, who work well together, and who can sort of work together to just keep improving and keep delivering a better product to our patients and to the community. So with that, I will toss the baton to Dr. Vega and say thank you.
Was excellent.
Thank you.
Hard to follow. I didn't think that Rachel was going to be doing so much of the stuff that I'm going to be talking about, but actually, great intro. I'm really excited. Let me see if I can share my screen now. Let's see, share. And I think I have to go like this here.
Beautiful.
Is that working for people there?
Yeah.
Okay. So the last time I gave this talk or gave a talk like this, I was looking back, it's been at least like probably 12 or 13 years. And I was asked to speak at the Northeastern Conference, which is a conference of plastic surgeons. And I was actually doing an updates on breast reconstruction and actually offering questions for the boards for board certification. I was just kind of going through what's the latest and common things we're doing. So I actually went back and found some old slides. And the slide was things that I was doing in breast reconstruction. And this is from 2012 or 13, right around that time. And a lot of the stuff that's mentioned here is still being done. There are some things I'm not doing. As much muscular coverage as possible. We used to put all the tissue expanders and implants under the muscle to cover and protect the implant. But that paradigm is completely shifted, and now we're doing above the muscle for almost everything. Always increase implant size at exchange. I would say in general, the idea behind that is trying to fill up the skin so that you have less aesthetic deformity. But with fat grafting and some of the techniques we're doing, we can sometimes actually work with that. And so that's not always an imperative. And then another big X is textured anatomic devices. Those have been associated with problems. Most importantly, for those who know the acronym ALCL, it's associated in a very, very rare but real circumstances of an adult large cell lymphoma. And it's really one particular texture, which will come up in a little bit later. But things we're still doing nipple sparing mastectomies, especially in the younger, healthier genetic mutation patients. The second one I couldn't get rid of because it's true, although we're doing things a lot different, alloderm or dermal matrices in compromised mastectomy skin. Because if you have compromised skin, putting a piece of prosthetic or something behind it is a really bad idea. Nowadays, we're making sure, I almost thought that Rachel would put in something about how we're looking at skin to make sure it's viable. And I did not put that in my talk, but I'll just say that we are now using a laser in the operating room that tells us when skin's viable or not viable. And it's keeping us, we're not doing the reconstruction if the skin's even a little bit compromised. The next one is the Bostwick autoderm technique. That's basically the WISE pattern, using the bottom pole of the breast to cover the implant or the tissue. And that's something I've been doing since. You could also think of that as the WISE pattern technique. Sutured tabs means that we put the expanders in, we can suture them down to the chest wall so they don't slide all over the place. I remember when I was early in practice, when YouTube was new, they had a patient who was moving her arm and her tissue expander would slide from her front all the way to her back and back. And it was like a party trick. That actually caused patients a lot of problems having expanders that weren't in the right place. And so the sutured devices are really helpful there. I'm still using the OnQ system, which is basically a pain pump device in patients that have the autologous tissue to sort of reduce the pain after surgery And Exparel is a blockade that we use as a long-lasting Marcaine, so it basically gives better coverage when available. Unfortunately, a lot of the hospitals in town don't want to carry it because of a small expense. They'd rather spend lots of money on other things. But I try to use that when I can. Aggressive stroma management. Everybody, we have to get the fluid out. Fluid around implants or around tissue expanders during recovery is a problem. It's probably the biggest, cause of infections and problems out there. And we're still fat grafting quite a bit. So the gummy bear implants, the Allergan style 410s, are completely out. The outside covering, even though they had beautiful shapes, it was a biocell covering, which was made from a natural sea salt solution. It was kind of poured on and made from that. But in those rare cases, I mean, I'm talking like 1 in millions is what we've published. People think it might be higher than that, but I've never seen a case. I don't know if I ever will see one, but those implants are gone. And I'm almost kind of happy about it because I think the shapes are better with the smooth round devices. And one of the weird things about the textured anatomic gels is that even though you got these beautiful shapes, the gels tended to be thicker and harder, and so they didn't feel as natural as the smooth round implants do. And then the other issue with them was that, and I saw somebody just recently, like 10 years later, they come in and the thing just, like sort of twists on them. And now they have a wonky shaped breast that just happened, and it would happen randomly, even though it's supposed to be textured and stick, sometimes they would unstick. So those are kind of out. And Mentor's memory shape is still in, I believe, but I've kind of moved on from that because I don't like the change in shape over time randomly occurring to people. This is from an old flap DIAP. I'm still doing the DIAP perforator. It's taking the old tram flap and removing just the fat and the skin. So let me see if I have a cursor here. That'd be nice. Not necessarily, but if you look at the screen, you can see the vessels kind of coming out from the underside of this tissue. Nowadays, we're taking just the vessels, the fat and the skin from a tummy tuck scar. We're closing the rectus sheath or closing the muscle coverage and then closing it as a tummy tuck and then making breasts out of the tissue. And that's kind of what I did my fellowship in and where I got my start. If you had known me from 15, 20 years ago, you would have been seeing only these kind of flaps and a lot less implants before I got started with the whole range of breast reconstruction. And this would be from an old talk. Somebody comes in with failed implants. We put a flap up there, and I just wanted to show people kind of quickly, what we're not talking about today. So also the gracilis is when you take the inner thigh, fold it up, connect it to the internal mammary system, and we can make breasts out of that. And just another little quick slide on that before we went into the real talk. So one of the things I thought it'd be fun to talk about is what is the problem with the classic submuscular reconstruction that made us turn around and say, okay, we're going to do this differently. And I would say this is a classic submuscular reconstruction. You have a transverse scar across the breast, and you really lose the normal anatomy of a breast. The breast should have a conical anatomy. There should be a projected nipple areolar complex in front of the mound. And what this transverse scar does is it tends to kind of limit the expansion and normal look of the breast on average. On top of that, the muscle tended to hold the implants high and tight, and you'd get these underprojected, poorly defined lower poles. And over time, that wouldn't get better because the muscle would keep the implant up and the skin would loosen over that. So you guys have seen out there, you will see, and I'll show you more of the problems that we had with that. So even though the submuscular reconstruction was a hardy reconstruction in terms of coverage of the implant, and it was the traditional way we did it for years, I was convinced to turn it over and change it when I saw some of the stuff that made the aesthetics a lot better. So one of the big ones is the WISE pattern autoderm. I'm glad that Rachel brought that up before so people aren't surprised by it, but it's basically is trying to preserve the upper pole skin of the breast and then fold that upper skin over the entire new reconstruction, which tightens and elevates the breast position and also kind of hides the scars, and patients will call it hidden incisions as well. So what the WISE pattern autoderm does, which I'll show you some more examples of this, is it manages dead space. So if you have this enormous breast or large breast, everybody knows the complications associated with breast surgery, not just plastic surgery, but all breast surgery, and especially prosthetic or implant-based breast surgery, is dead space, having too much skin, too much room for fluid to collect, for things to go wrong, for collections to happen. And so this thing reduces the size of the overall envelope where the breast is and reduces your complications. So managing dead space, you're reducing your complications. You allow for a natural conical shape to the breast, which Rachel showed some great examples of, and I'll show a couple more. And with the autoderm part, which may not be very well understood, you're taking the lower pole skin and you're basically covering your implant with that so that you have double coverage over a critical area of the breast where having a problem would lead to bad results. And so this is something I picked up from actually a surgeon who's long passed, but he's just a very brilliant a gentleman who talked about this back even in the 60s to 70s. And so you get better prosmesis. These are some of the incisions. This kind of goes over the idea of a mastopexy or that wise pattern lift. You can see that the green on your screen on this breast is the part of the tissue that's removed, and the upper skin becomes now the full breast. So here's an example of an extreme patient. These are the incisions that I was planning on leaving the skin of the upper breast. If you look at her carefully, on your left-hand side with her breasts just low down and ptotic, the upper incisions are going to keep that skin above that to make the breast, and all the lower stuff, including that large nipple areolar complex, goes. And then with her holding her breasts up, you can see that lower pole skin, so everything below that incision on the right-hand side of your screen, I save that skin, and that becomes kind of a natural hammock to help cover the expander and continue to cover it with the use of the acellular dermal matrix and make nice breast mounds. Here's an example. Part of my screen's covered because of this, the way this is, but I'll try to explain it the best I can. This is the same thing. Ptotic patient, the funny blue thing in the middle just covering up an identifiable scar, tattoo. The incisions are designed right there in the middle, showing where the incisions to remove the breast tissue are. And then on the very right, arms up, you can see the upper skin covering the entire breast. And that little tiny vertical incision right in the middle is basically the same as the sort of pointy part of the middle incision there in the middle screen going up. So it kind of creates more of a natural breast shape. Here's the same thing with arms down. And the vertical lines on the patient's drawing in the middle just kind of show you the midline of the chest wall and the midline of the breast, but don't really, there's no incisions going on there. And the perforated dotted line in the middle is the inframammary fold position, which tells me where the nipple is going to move to for the final reconstruction. And that's her with a tissue expander in, and then she gets her, she got a tummy tuck. It wasn't part of a reconstruction, but then she got her natural breast implants, and you can see arms up, arms down, kind of a much more natural, acceptable cosmetic shape. This is just another one of my older slides, but it's the same idea, that sort of wise pattern incision. You can hide the incisions, people call them hidden incisions, and it kind of can create a very nice breast mound. It's elevated and nicer, and patients, even with mastectomies, can still look good and feel good about themselves. The next thing I want to talk about is this ADM, which is acellular dermal matrix. There's lots of different brands of ADMs out there, but basically it's really changed the way we do reconstruction, because now instead of covering the expander and the implant with muscle, we're covering it with ADM, which has a lot of benefits. And the benefits are you're going to see reduced encapsulation. Encapsulation is when the scar tissue around the breast gets tighter and creates a deformity in the breast. And there was a lot more encapsulation with submuscular breast reconstruction because the lower pole of the breast wasn't really being managed well. And so it tended to tighten up and fibrose and create some of those deformities like I was showing you earlier. The ADM also allows for a fat grafting plane. When you have the muscle there over the implant, the muscle was a great plane to do fat grafting, but now having the ADM, which is going to reduce your scarring, but it's also going to give you a plane where you can inject fat, and the fat grafting allows the breast to look more natural. One of the downsides of ADM is it bottoms out, and we can talk about that, but there's different techniques, and the technique I use minimizes bottoming out, allows the breast to stay higher. But when people have that problem, a lot of times it is the ADMs that are the problem with that. It's a very expensive product. It's only available in the hospitals. So anybody who's having this kind of surgery will be done in a hospital at this point in time in Rochester. Hopefully one day they'll let us do it in the outpatient setting because it makes a lot more sense. We still use the magnet finder, and there's a typical example of a tissue expander that goes below the skin of the breast, and we access it through one of these butterfly ports, and it goes right into that magnet that and goes through the skin, and we can fill things up that way. That's an old slide as well. And this is just a rendition of the older way of doing it when you had the muscle covering the expander implant and then being pushed out. So also going back in time, this is a full muscular coverage, an example of a patient with a mastectomy. And then this is sort of how ADM evolved. We started putting it as a sling below the muscle, which also helped improve some of the outcomes, but really wasn't as good as what we're doing now, which is to cover the entire new reconstruction with ADM. The one that I prefer using is named Dermacell, and I really like this perforated stuff. It stretches, it covers the implant better, and the perforations allow it to become part of your body. Even though it is a piece of cadaveric, cellularly treated, like kind of like a leather, it really gets, the body recognizes this and removes the current complex and turns it into its own tissue. So even though it's an insert, it really ends up becoming yours, and it's your body without any sort of any other person's cells or any chances of you getting sort of a chimerism or anything from it. So here's a perfect example of why ADMs work. This is a typical patient that comes to my office for revision. She's unhappy with her reconstruction. You can see that she has the same problem we were talking about earlier. The muscles holding her implants high and tight. She has a tight indented crease where the transverse incision was. The lower pole is undeveloped. And then she has all this extra skin kind of sliding off the side of her chest wall. So I took her back to the OR, and we do a reconstruction with ADM. And you can see after a stage of going through an expander again, she gets a small breast, which is what she wanted. She could have more upper pole fullness if she went to a bigger implant, but a lot of patients prefer smaller implants, so we just try to fat graft to make that area look as normal as possible. So the progression is from your left to your right is her coming with an unsatisfactory result to a better result. I wanted to touch a little bit on nipple-sparing mastectomies. I think Rachel talked about that adequately and went through that very well. I'll just run through this quickly for myself as well. So I think in general, the results with nipple sparing are cosmetically superior. Having your own nipple makes it look and feel more like yours, and the patients who get this or can get it are usually very happy. It's best, obviously, for patients that don't have cancer, because if you have a cancer and you're dealing with, you got to get in quickly to get your, your chemotherapy or your mastectomy or your radiation, and you don't have a good nipple position, it's really something that we can't offer to everybody. There are pros and cons with different incisions around the breast, and I can give you some of my thoughts about that. It's an important thing to say is that the pros and cons that I'll mention or try to give you guys, it's for you. It's not something you can say, well, my friend had this, I want the same thing. It doesn't work that way. One patient whose inframammary fold incision is perfect will be a bad idea for somebody else. And somebody else's lateral incision will be a bad idea for someone else. I'd say that there are pros and cons to these incisions, but leave it to your plastic surgeon to help you come to that answer. So the position of the nipple areolar complex is important. Why is it important? Because when the nipple areolar complex is not in the anterior projected portion of the breast, you tend to develop deformities of malposition of the nipples. And if you've ever seen a bad result with nipple sparing, it's going to be the malpositioned nipple. One's going off this way, one's going up that way, or vice versa. It just looks weird and patients don't like it. And I would say it's kind of sad that that people have had to live that way, but unfortunately, it's one of the downsides of this operation. So here's a couple of scars. The one, the A scar, I don't think I've ever even performed that one, and so I wouldn't recommend it or use it. The B one I've used a lot. I think the downside of B is you can tend to get a little bit of a pull to the nipple of the incision. So sometimes you can have a problem with the incision pulling off, or the nipple pulling towards the incision. C is kind of more classically like an inframammary with an extension out to the side, sort of way to hide the incision. I would say that one's we've used sometimes, but probably more commonly would be just this one in the inframammary fold where the yellow line is there at the bottom. So Probably the most common incision we use, the same as the breast augmentation or typical breast surgeries, would be right at the fold. And that would be another one that's good in some cases. Another one that we use quite a bit, I think Rachel showed this as well, and I kind of like, is that if you have a little bit of malposition of the nipple, if you take this upper sort of omega incision or incision above the nipple areolar complex with little extensions medially and laterally, you can reposition the nipple, you can save nipples on somebody who otherwise couldn't keep their nipples. And I think it's been very useful. Some people call it a bat wing incision. Here's some examples. This is somebody I wanted to show who's from my early days, one of my first nipple sparings. I think this was with Dr. Hetland back in the day. And she did have some compromise, if you can see, of one in the middle picture. So her picture on your left is pre-op. The picture on the right is early post-op. And then the one on your far right is like 10 years later. And what I wanted to show you that is that she had an inframammary incision, but she developed some skin necrosis or skin compromise. And even though it looked very, almost like there's a scar on the shadow of her breast on the right, her right breast in the middle of your screen, that ends up lightening, and even the partial nipple loss ends up becoming okay over time. A more modern example, mastectomies, tissue expanders in the middle slide, preoperative in the left slide, and then on the right side, the final result. And you can see even those omega incisions that are going around the nipple areolar complex, a lot of times they really just hide, and it's quite a good incision. Another example of the same kind of thing, on her left is pre-op, in the middle of your screen is tissue expanders, and on the right of your screen is her final result with implants in place. And then another final example, the patient on your left is pre-op. In the middle of your screen is after mastectomy with live tissue. And on the right of your screen is with a DIEP flap in place, taken from her belly and put behind this to make a natural breast. Another paradigm I wanted to talk about is this concept of prepectoral pocket change. I almost talked about it earlier, but basically what we're doing here is, if you look at this schematic on the top, on the yellow is your skin envelope for breast reconstruction. The brown is your chest wall. The red is your muscle in somebody with a classic submuscular reconstruction. So then if you go from the top schematics with the top three, go directly down, now take your eyes to the bottom, and you can see they're taking that muscle and they're putting it back down against the chest wall. This is a lateral view, like looking through the side of the patient. And now you can put the implant in that subcutaneous space. And that's where I think some of the better looking breasts come from. But it also has another more important mechanism, is that a lot of patients, I would say probably in my guesstimation, 10% of patients, 20 would be too high, 10 is probably a little on the low side, develop something called musculoskeletal pain. And what happens is that they start to feel discomfort in their chest wall after having had implants for a while. It usually doesn't happen right away. I normally see patients several years later, probably an average of about 7 years, and they just come in and they say it hurts here on the side, when I'm doing stuff, when I'm active, and it bothers me. And if they're coming to see me in the office, it's not just a little bother. It's a big enough bother. They want to come, they want to talk about it, they want to do something about it. Well, this ability to change the pocket and move the muscle back down and put the implant in the prepectoral space actually eliminates that musculoskeletal pain. And that's been a really great discovery for us, because doing that now can offer a lot of help to a lot of patients. I would say with breast augmentation, it happens, but to a degree, you see it with breast augmentation rarely. You see it with breast reconstruction, probably because of all the scar tissue in the breast moved a little more often. It also, by doing this, you eliminate something called animation deformity. For those of you who do not know what animation deformity is, it's when there's a movement of the breast implant underneath the skin with the movement of the arms that kind of completely deforms the breast. In some patients, it drives them crazy. When I finished training and I was a young plastic surgeon, I'm going to show you a video later in this talk of somebody that I dealt with who was very unhappy with their animation. And I talked to all the plastic surgeons in town. I was like, okay, so what do we do? What's the best way to fix this? And every single surgeon told me, there's nothing to do. It's normal. That's the normal way that this looks. I knew back then that it was a problem, and now we're actually doing something about it. So this is one way to take care of it. So the breast can be cosmetically improved when you get those scar layers and put them back down against the chest wall, put the muscle where it belongs, and create a new pocket. Because you're delaminating the mastectomy from the muscle, it's almost like you have to think of it as going backwards in time. It's almost like you are going back to the day of your mastectomy. So now your skin is right away has been delaminated of blood supply. So I don't just put the implant from behind the muscle to the front of the muscle, because if I did that, I'd have a lot of patients come in with problems. And the biggest problem would be dead skin or problematic healing, because the implant would hurt that skin if it didn't have time to heal. So we go back into a tissue expander, and sometimes that's a very quick, easy expansion, and other times you have to take longer to make sure that skin slowly gets to where it has to go, because the most important thing is to make it stable and to get a good result. It's less risky than doing a flap. I used to think to fix this musculoskeletal pain, you'd have to go into a flap from an implant, and I did that for years with some patients. But this is a really great way to do it without having to do the bigger surgeries. Here's an example. This patient is about 8 years out from a bilateral nipple-sparing mastectomy. You can actually see her inframammary fold incisions are asymmetric. She was bothered. She had sort of a nicer result early on, but then she started to develop this bottoming out on her right breast. You can see her with her arms up a little better. She was unhappy with this. She had some discomfort. And a lot of times that discomfort comes because that muscle's pushing over the implant and pushing it in different directions, causing deformities on the breast. So she was taken back to the OR. She went back into expanders. She had the fold fixed, and then she, from the middle screen where the expanders are to the final result on the right, she had implants placed, and now she's very happy with a stable result and doesn't have some of that animation. This was one you saw earlier. I originally had it here and put it up there just to show the example of alloderm. Same thing, the patient had these taken out. So everything's delaminated, muscles sutured back down to the chest wall. She goes back into an expander with ADM. So you have that dural matrix over the top. And then I adjust the skin to fix the pocket without even having to remove the skin directly, just redraping it into the right place. You can see that her lateral chest wall, all that hanging skin now, because when the mastectomy is performed, what happens is all that skin, when you have a bigger breast or extra skin, it just hangs wherever the mastectomy surgeon left it, if they're not like Dr. Farkas and thinking about these things and fixing it right away. And so it's not unusual for us to see this kind of stuff on a regular basis in our office. So then the next question is immediate versus delayed. I think Rachel showed some great stuff on that. If you had to ask someone like myself, experienced plastic surgeons, a lot of us out there who do cosmetic, breast, as well as reconstructive surgery, which is better, immediate or delayed? We'd all have to say that delayed is superior for everyone. Why? Because delayed is safer. It's going to get you to the same result. It just needs the input of the plastic surgeon designing and helping the breast surgeon do the right incisions. There's less interference for the patient in terms of chemotherapy and radiation therapy. Delaying improves your cosmetic outcome instead of dealing with, well, the skin was kind of compromised. We waited and, oh no, you lost some skin. So now we're going to go ahead and resect the skin and try to fix it after that. Once you're dealing with compromised skin and removing mastectomy scar and necrosis, et cetera, you're going to have aesthetic problems. So the aesthetics have gotten a lot better with trying to plan these things and doing them correctly and make sure the skin's viable. And it is hard to coordinate sometimes. And so you're not going to always be able to get a plastic surgeon to be there for all of your surgeries. It'd be nice if that were possible. And I used to do that a lot in my younger days. And I would love to do that for everybody. If I could duplicate myself and have one Dr. Vega with Dr. Farkas every day, that'd be great. And then the other one does the other patients. But that's another issue. And the patients like the immediate. Nobody's going to say, no, I want to do it delayed if I can do it immediately. And I can't see the rest of my slide there, but delayed does work. Here's an example. This patient, she had previously had a breast augmentation, actually in a foreign country, or maybe, I think it was in a foreign country. Anyway, she came here, she had ruptured implants, but her implants were removed. We let her skin make it because her skin was very compromised by the mastectomy. And then we went back, we put tissue expanders in, and then she was changed over to final implants and is very happy. And this is just an example of why delayed actually does work. The next thing I want to talk about, I think Rachel touched on this as well, is you can also perform a mastopexy or a breast reduction as part of your reconstruction. And these are the different kinds of incisions. I would say there's probably 3 key incisions. One is the Wise pattern, where you have kind of like the anchor, where you're involving both areas of green. You're removing the green there in the center and the green on the sides. If you're doing a circumvertical or how would you say it, lollipop, or vertical mastopexy or circumvertical mastopexy, then you're dealing with the one just in the middle green that looks kind of like a snowman, with the nipple going up into the snowman's head and then the bottom just going into a straight line. And then one other one, which I do very occasionally, is I'll just go right around the nipple itself and lift that by itself. And that's in unique circumstances. So same thing here. Wise pattern's the one on your left, the vertical scar or lollipop scars in the middle, periareolar is on the right. For those of you that have questions about this, I can tell you periareolar is only good for moving the nipple, but not lifting a breast. So never think of the one on the right as, I had my breast lifted through this, because it doesn't work. So these things, these techniques allow for someone who has the time, and we can make it work, to have a nipple sparing mastectomy and have a superior cosmetic results. It fixes the problems of volume. If somebody's got a really big breast, you can't just save your nipple with that big breast. You're going to have to do, as we showed in an earlier slide, where everything comes off except for some of the skin. I would say it's cosmetically superior. Patients that can save their nipples are always happier having a nipple if they can. And the studies are pretty clear, showing that it doesn't increase their chances of getting cancer because they leave a nipple behind. And I say to wait at least 8 weeks between the stages. So if I'm doing a breast lift, a mastopexy, or fixing the nipple position, doing a breast reduction, then I'm waiting at least 8 weeks before she has her mastectomy and next surgeries. Unfortunately, you're going to go to at least 3 surgeries now. Why? Because you have to have the mastopexy to fix the nipple position. And then you're going to be having, even if you have a mastectomy with tissue expanders at the same time, you still have that third and final stage of putting in a final implant. For those of you who are like, well, I heard somebody does it immediately at the same time in one stage, direct to implant, I would say that is a whole different topic. And if direct to implant was such a great way to do it, we wouldn't be fixing the ones that don't turn out so right. And I would say that even the best surgeons I know that do that, they tell me that their revision rate's at least 50%. So if you're taking half of your patients back to fix that, then you might as well just do it the right way, which we've done in 2 stages, and in this case, 3 stages. This is an example. So this patient, there's her nipple is a little bit on the low side, and she's a high risk of sliding, right, left, sideways, everywhere. So she gets a mastopexy, she gets tissue expanders, and then she gets final implants. And you can see cosmetically appropriate result for somebody with a little bit of ptosis. Another patient, same thing, large breasts, gets a reduction mastopexy. Then in the middle screen, you can see she's got tissue expanders in. And then the final result, she also got a tummy tuck. She ends up with very natural looking breasts, maintained nipple, and a breast implant. Another patient goes through several stages. She has a mastopexy to fix the nipple position, fix the skin. She has kind of wonky looking tissue expanders there in the middle. But then for the final, we fix the breast envelope, put a natural breast implant in, and there she goes. Another patient, looks like her nipples are in front and okay, but she's got a very long distance there, and she has a very loose skin envelope. So she gets a mastopexy and then expanders and implant. So animation deformity. Animation deformity, as I was saying, is when you get that abnormal movement of the breast implant, and I actually have a video of this. And let me just run through this first. It's a big problem for patients with submuscular implant reconstruction. I kind of got really good towards the end of my submuscular days of making sure this didn't happen. There's a lot of different characteristics that go into this, but I saw it very infrequently. And a lot of it has to do with the plastic surgeon's decisions about how they do the submuscular pocket. But even if you're doing it, if you do it for everybody, you're going to have problems. For some patients, it's incredibly disturbing and they're very unhappy. And for other patients, they're like, oh, it doesn't bother me at all. But the ones that we see that are complaining about this, obviously they're being disturbed. It leads to malposition of implants. You may not think this, but imagine having this big muscle over the top of you, pushing you around all the time. So if it's going to push you out to the side, then you're going to have an implant malposition to the side. If it pushes down, you're going to have an implant malposition down. if it pushes inferiorly. So all these different results come from and I see this both in cosmetic patients and in reconstructive patients. In fact, the first patients I ever dealt with this was the cosmetic ones, where these unusual, it doesn't happen very often in cosmetic, these girls would come in, they'd have these, double bubbles with the malposition implant, and it was really the muscle that was pushing the implant into the wrong pocket. And by fixing the muscle, I was able to fix their breast implants. And so here, let me see, I think this does work. I played it earlier, so I'm gonna try to get this to work. Here, so we're asking her to move, and there she's doing it there.
Firing both sides, right?
She's firing.
Can't do
So-
anything to this side.
So her right breast was radiated. I did both of these. She had what's called metachronous breast cancer. So she had mastectomy reconstruction implant on one side, and then got breast cancer on the other side, mastectomy recon other side. Her right side is radiated, so the radiation provided enough tightness to that pocket that when she fires, it doesn't move, which all of those out there who have had radiated breasts, they kind of understand that concept because they have that kind of fibrosis, that kind of tightness to their breast. But let's do this again. Let me just turn off the volume for this. She is firing both sides, but look at how her left side does that weird movement. It drove her nuts. She was a golfer, and she would go out there to the golf, and she'd say, well, all the guys are staring at me because I'm just trying to play golf and my boob is moving. And so we ended up doing a surgery that I'm doing for patients with this, where I release the muscle fibers across the front of that implant. And what it seems to do is it turns off that overactivity and settles down the implant. The downside is you have to have the surgery and the muscle's got to be released. And I would say that this is something that's not standard or routine by any means, but it's something that I've been doing for a while and that I've actually started slowly getting into. And now I'm trying to figure out if we can fix some of the musculoskeletal problems by just getting rid of some of that muscular activity. And I couldn't answer that today, but I would say that's one of my goals. So thank you. Looking forward to the summer and some sailing on one of the lakes. And thank you for coming, and I'm happy to answer questions. And I'm happy to work with Rachel, who's just a fantastic breast surgeon, and I'm really happy that we work together.
Thanks, Steve.
Okay,
Feeling is mutual.
so who's reading questions?
I've got the questions, and we have, I'd say, 20 questions. So I hope I can get through them as
Oh,
quickly as
I have to do
possible.
something here.
It's already 8:12. I want to be mindful of everyone's time. Thank you both so much. I learned a lot. That was fascinating. So I will just launch into these questions and get through as many of these 20 questions as we can. Some people specified who they wanted to ask questions to. Some of them I think are to both of you. So we'll just do the best we can. All right. And these were in the order in which I received them. For Dr. Vega, when should you replace your breast implants after having reconstruction? Is fat grafting an option instead of replacing the implants? And how successful is that procedure? How much experience do you have with this? Does insurance cover this option? That's a whole bunch
Okay, so that's a lot of questions in one, but I'll try to keep them.
of.
Okay, anyways, let's start with this. A lot of doctors will tell you that it has to be every 10 years. I can't see myself, so I hope you guys can see me if I'm talking to you, but either way, if they say it has to be at 10 years, I would say a lot of us don't necessarily believe that at 10 years you should change your implants or you're required to. It doesn't mean we won't do it for you if you'd like that done, but if surgical devices have a 10-year window, and that's the way that they're approved by the FDA. So your orthopedic surgeon is putting in your knees, putting in your hips. He also gets a 10-year window for his implant, but it doesn't necessarily mean that he's going to come back and say, okay, time to change that hip out. So the way I look at implants is it's sometimes it's just a business opportunity to change out implants, but certainly enough people have problems with either malposition, skin redraping, aesthetic deformity, musculoskeletal issues. It wouldn't be something that you couldn't do at 10 years. But if you come at 5 years, there's a problem, we're going to change it probably. If you have other issues, we're going to change it. So changing implants, I don't think should be an absolute requirement. But I think that it's a reasonable request from patients. In terms of fat grafting, I've been doing it forever. I didn't talk about it in this talk because it was a new thing, probably 12. Actually, I've been fat grafting since I finished residency in 04. So I finished my fellowship in 05. I basically grafted our career. The fantastic part of what we do. It has for reconstruction. It should not be the place of changing, or it can fix it without doing anything else. Surgery in the last generation. And yes, I have a lot of experience. I've been doing it. I've even taught courses on it. It's something I do.
Great.
Is there something else I missed, or is that everything?
Well, there were some questions related to when people would like to exchange those implants. Do you happen to know what the insurance situation is in terms of coverage, or is that sort of a case-by-case basis depending on?
Once you've been diagnosed with breast cancer, they have to cover your surgeries. They don't like it, so they're not going to want you to just come in and keep changing. And your doctor's not going to just say, oh, you want to go big now, you want to go small now, you want to change now. I would say I've only seen them push back hard when someone is continually coming and asking for an upgrade, like, bigger size, okay, no, bigger. And what happens in my practice actually works really well is I have somebody whose breasts now are so nice looking, and they're asking for little tiny things that I think is beyond the scope of reconstructing the breast, which I'm pretty picky about it. So you're not going to see me doing this very often. But once they've done that and they're asking for more, I say, okay, I'm happy to do something else for you, but this is cosmetic. And every single time that's ever happened, the patient's paid for it and they've done it cosmetically. And I think that's appropriate. But I would say in general, it's covered by your insurance. If your insurance covers anything anymore, who knows, right?
Yeah, that's a
But in
great.
New York State, it's required, yes. And there's no
Okay.
statute of limitations.
That's fantastic. That's really encouraging. Okay, for both doctors, what are your recommendations for receiving breast screenings after having a mastectomy with reconstruction?
You
I'll
want
let
me to take
Rachel
it?
answer.
That's me. So, I think it's pretty clear that a mastectomy does not eliminate your risk entirely, and that even though the breast gland is removed, we know that some of the tissue really extends to the undersurface of the skin. And so while the National Cancer Guidelines will not recommend imaging after mastectomy, I think that imaging after mastectomy is a thoughtful approach, and it's a smart way to do it. I don't force patients to have imaging after mastectomy, again, because the guidelines don't recommend it, but I definitely encourage it if the patient asks about it. In terms of timing, it's a little bit different than routine imaging that patients will have, after age 40. So I would say that for timing after surgery or reconstruction, you really want to check with your doctor to see when they feel it is safe to do it. In our practice, we usually try to do the MRI as the first form of imaging because it's non-compressible imaging. And so if they've had mastectomy and reconstruction or balancing procedure, we really don't want to compress the breast for at least 9 to 12 months. But after that screening, depending on what surgery has been done, mammogram, ultrasound, or MRI, if we can get insurance to cover it, are all great imaging modalities. And most of our institutions in Rochester will actually keep sending messages to the patients and let them know that they're due for their screening.
Okay, great. How long do you like to wait before performing surgery on skin that has received radiation?
That is not, so I think this is one's from me.
Yeah.
There's no one answer or, one size fits all for that one. In general, if you want to pick the conservative board certified sort of plastic surgeon answer, it's a whole year. I've been in panels before, we've talked about this, and I think 6 months for a lot of patients is okay. But before that is very dangerous. And I would say buyer beware. If your surgeon says, oh, we got to change this out right away, I'd say don't do it. Radiation is associated with the highest failure within those first several months afterwards. So even though the incision looks perfect, you literally could be going to the store or something 6 weeks later, and then the incision's open. And you're like, well, it's really, really detrimental to healing. So that's a loaded question, but that's the best answer I can give, sort of in a generic generic way.
So err on the side of caution, give yourself time to heal. Okay.
At least 6 months more.
Okay.
And patients who are in the audience who know me or my patients, you won't, it'll be common for me to say, I know a year is good, but why don't you wait a year more or two? And the ones who do, they got much better. It makes a big difference. The longer you wait, the better. But go ahead.
Okay. Many women don't realize that they will have little to no sensation in their breast or nipple after a mastectomy. What are your thoughts on nerve preservation mastectomies to give women the opportunity to feel like themselves again after mastectomy without the constant reminder of numbness? Is this a procedure that you offer to your patients?
I think Steve and I both have opinions on this. I can go first. You
I'd
can
like to hear
go.
Rachel's first because I'm not sure what hers is. And I know mine's probably misinformed, but go ahead, Rachel.
So I think that this is, I think, a topic that sort of stems from something else. It's, how complete is your mastectomy? And I've shared with patients all the time that, patients go for second and third opinions, interviewing surgeons, when really the question that they want to ask is, how complete is your mastectomy? Do you remove all of the tissue? And we know, and Dr. Vega knows better than I do, that there are different degrees of removal. And what you're really looking for is that sort of Goldilocks. You want to remove just enough that the skin survives and not too much where the skin can die. And you also don't want to leave breast tissue. And I think that a lot of the things that are done on the West Coast, which is where they do a lot of these nipple preservation, or not nipple preservation, I'm sorry, nerve preservation mastectomies, are leaving a large volume of tissue underneath the skin. And so I think that while they're doing something that resembles a mastectomy, or what they call a mastectomy, I think I would call it a moundectomy, removing just sort of the bulk of the glandular tissue underneath the breast. I hope that eventually we'll come to some point where something can be done for nerve sensation. But I think at this point, the mastectomies that are done where the patient wakes up after surgery and says, oh my God, I can feel everything, is just not really a complete mastectomy. What do you think, Steve?
Well, I think you hit the nail on the head. I didn't know you were going to go in that direction because there's a lot of mumbo jumbo out there. But basically, yes, what she's saying, I mean, I'll never forget the young, breast cancer survivor from California that comes, has gorgeous breasts, but is dealing with metastatic disease after her mastectomy. And I'm thinking she didn't have a mastectomy, she had like a lumpectomy. And I think that I've been on this for 10 years or more. So those of you who know me, been in my office and talked about it, I say, well, there's your 90% mastectomy, and then there's your 97%, your 99. When you get higher to 99 and your skin's alive, you're not going to have cancer problems like some of these other people are going to have. And I know that people that have been breast surgeons like Rachel that have been doing this for a long time, they tend to get thinner as they're in practice longer because they've seen recurrences and problems with the thicker mastectomy flaps or the edges of the mastectomy where there's still a lot of breast tissue. I've had upset patients in my office saying to me, how come I went to get my mammogram and they're telling me there's all this breast tissue up here? And it's because people are now wisening up to the reality of what this is all about. So I never knew that that was conflated with nerve preservation. So what I was going to say is with a DIEP flap or a free flap or a tug, you can actually take the nerve from the flap and connect it to one of the intercostal nerves. And theoretically, I've definitely seen this, you can get faster sensation return with a flap. When somebody tells me they had a special mastectomy to save nerves, I'm still sitting here doing, and then Rachel maybe answered my question. I'm like, what are they doing? Like, how do you can't grab the skin. So I think that what Rachel's saying is probably what's going on, which is just leaving more tissue behind. So I would say buyer beware. And I'll tell you something else that's really fascinating. Not only do patients who have nipple preservation have the reaction to cold because it's in the skin, I've literally had patients tell me that they have sexual function off of their nipples. And I believe very strongly that this is something that your brain is in control of. It's called, what's the word I like to use? It's basically neurologically teaching your body how things work. It's almost like, I use this constant example in my office of the gentleman that I replaced his thumb pad with the back of his hand. It took a fancy flap from the back of his hand, turned it over, was like, it's right here. And then it's now here on his thumb pad. And I met him accidentally 3 years later, searching for a sailboat out in Canandaigua Lake. And he's like, hey, Dr. Vega, you did this thing for me. He goes, you know what? For the first 2 or 3 years, I always knew I was touching the back of my hand. But then one day I woke up and it was my thumb. And now my brain knows my thumb. I know it's my thumb. I think that's the way nipples and nerves work in the breast. I think people can teach themselves that this is what this means. And so I would go as far as saying, even without worrying about did I spare nipple or nerves, et cetera, that this sort of ability to sort of train your skin and your body to feel things is real. And also, and I guess Rachel would agree with this too, patients that say I have no sensation, it's totally numb. If you stick a needle in that skin after a year or 2 or 3 years later, it hurts. If you put something hot for it's hot. The different fibers for different sensations come back at different rates, but those nerves definitely go back into the skin over time.
Right. Over time. So those are the two things that I wanted to point out. I don't have experience with that nipple sensation, but I think that that's fantastic and I could see how it would work. I think that nerve sensation does come back over time, but you're right, it's years. It's usually, I feel like it's usually our patients that come back at 2 or 3 years are starting to describe sensation that they have. So the sensation is not gone forever, but again, they always do describe it as being different. And second, if we sort of triggered anybody with that sort of, did you have a complete mastectomy, was enough breast tissue removed? There's really an easy answer, it's breast imaging. The mammographer will tell you if there is residual breast tissue and if you should continue imaging. So if you're concerned that you feel like you may have had not enough removed, it's time for some breast imaging.
Okay, great. All right, let's keep going. What are the options for redoing implant surgery that was originally performed nearly 20 years ago? What are the options to minimize ongoing discomfort from those old implants during vigorous activity? And you talked about that musculoskeletal.
I think that patient's probably dealing with what we just talked about, the musculoskeletal pain associated with the submuscular pocket. Now, the other thing that happens, and this unfortunately happens too often in my office, I get a patient with implants from 30 years ago, 40 years ago, and they're completely ruptured, they're encapsulated, they're like rocks. And when I examine the patient, I'm like, oh, doesn't this thing feel unusual to you or hard? And they tell me that's what they always felt like. But it's because we don't notice our bodies changing over time. And so somebody who had nice soft implants, when they were 20 or 30 now may not notice that. So sometimes the pain can be associated with an aggressive capsule formation and ruptured implants, but probably with vigorous activity, it's going to be the musculoskeletal thing we just talked about.
Okay. So there are options for dealing with that.
Oh, absolutely. Yeah.
They don't have to suffer through it.
Not all life is suffering.
Yeah. With thin skin, can someone still have post-muscular placement of implants returned to above the muscles?
That's a really good question. I would say depends, but most likely, I would say possibly yes, it depends. I mean, I have patients currently where they're under the muscle because I have to put them under the muscle. If they come to me next year or the year after and say, hey, can I change now? I'm not going to say yes. It's because they were so thin that I could barely get that to work. And then if they're worried about it that much, they also have to understand that if they're that thin and we're able to get away with a swap, is there going to be so much scar tissue that I can't get fat in there and make it look natural and nice again? And that's an issue. So I would say depends.
Okay, case by case basis.
Yeah.
What is the difference between the procedure for a tummy tuck and the abdominal portion of a deep flap surgery, or the DIEP, as you call it?
I could talk about this for an hour.
Yeah,
Let's
please
make it
don't.
easy. The easy answer is the DIEP flap, you got to find the perforating vessels, and the perforating vessels tend to be around the belly button. And so if you're looking at like a 10 centimeter area, at least 5, and what if your perforator is 2 centimeters up to the side? Now your scar down below has to be a little bit higher. So probably the most common thing is the scar is a little bit higher. And probably the second most common thing is we're not there for aesthetics. We're doing a breast reconstruction. So it may not be the most cosmetically perfect. Although I think a lot of them, I mean, I'm very focused on the cosmesis. So a lot of mine, even if I have to go higher, I try to do it in a way that still looks good. But I've seen some pretty bad stuff out there. I think I've had patients come and tell me, do you think that this famous doctor had the medical student close this part? Because this is all off. And I'm like, no, he was just focusing on the breast, not on the belly. So it's unfortunately a big difference in that regard.
Okay. So you did talk a little bit about your thoughts of direct to implant right after a mastectomy instead of a patient having expanders first. And it sounds like ideally delayed reconstruction is advised, correct?
I really worry about somebody who's doing direct implant with everybody in terms of what Rachel said earlier about the thickness of the flap. If you give me a centimeter of thickness more on every flap, I can throw implants on everybody. I just worry about who's getting them and why they're getting them. So with the mastectomy, and this is funny because this has come up in our national meetings. You have some of these guys down south who are like, well, I do a mastopexy, move the nipple, fix the skin, do the implant, and here's my result, DTI. And then Joe Disa from Sloan Kettering gets up and says, well, we haven't seen a mastectomy like that at Sloan Kettering for 20 years. And I would agree with that 100%. Like people that are serious about mastectomies are not able to do DTI in everybody. And if they're doing DTI in everybody, including malpositioned nipples, something's going on in terms of the thickness of that breast. And I would say they should keep imaging. And I think Rachel would agree with that statement. You've seen it, right, Rachel? You know the locations where it happens and she sees them and she's like, they still have a whole bunch of breast in there. So
Yeah.
I wish I had the crystal ball and knew which patients didn't need a lot of breast removed. Wouldn't that be great? Like, okay, you can have,
Yeah.
just the central breast taken out and have a beautiful breast after this because you're most likely not going to get anything. I would love to know that. That would be a really important thing to know.
That would be a great superpower.
It
We'll
would be a
hope for that.
superpower. That's right. Maybe AI will figure it
Um, Another person was asking, when she does chest presses at the gym, the mastectomy side begins to feel painful, and is that a normal sensation?
I'm just wondering if they had an implant reconstruction or not.
Did not say. I don't
Yeah,
believe,
it depends on so many things.
because it could be that musculoskeletal issue that
Yeah,
you mentioned.
absolutely.
Um,
Mhm.
But ideally, it does sort of sound like if somebody's having a lot of pain, that they should feel
Have-
confident to seek support
They can talk to us and we can try to help them understand if yeah, absolutely.
instead of suffering through it and feeling like that's the only option, is that there is help and there are
That's correct.
possibilities.
Yeah.
Let's see. Are dog ears something that could be addressed at the time of implant replacement?
Oops.
Of course.
Yeah.
Okay, that's an easy one. How long after initial surgery can one go back for corrections with a deformed, uneven outcome?
Depends.
Once again, depends.
If you're my patient, you have to wait a long time. I'm kidding.
Um, we talked about that 10 years. Yeah, is that accurate? Insurance covers it. Good.
I've
Are
had patients come to me 30 years later for reconstruction. They just couldn't get it done. And then they finally came and like, I'm going to do it. Okay, let's do it.
Great. So no statute of limitations on that.
No.
Are expanders required prior to DIEP flap?
No. Oh, I'm going to take that one.
Yeah, go ahead, Rachel.
So we didn't talk about this, but we could. So I think that and the person who is asking the question can correct us if we're talking about the wrong thing, but there are surgeons in our community who require tissue expander placement after mastectomy while they wait for a DIEP flap, meaning that Dr. Vega can't do the flap immediately. And so they want something holding the skin in place. There's absolutely no reason to have anything holding the skin in place. Most patients who choose to have a flap are doing it because they don't want implants. And so there really is no reason, if the patient does not want to have tissue expanders placed, to put them in. We think, and I'll speak for Dr. Vega and then he can speak for himself, we think that it's done because some surgeons don't know how to put the skin back together and sort of create the appropriate closure in anticipation of the flap. And it's not super complicated. It's that wise pattern incision for most women who have large breasts. We use that incision, which basically puts the skin together and readies it for a DIEP flap. If for some reason they are trying to use their skin and they want to have that look that patients with an implant have, with that wise pattern that you saw in a lot of the images that we showed, then they can have a tissue expander placed, which expands the skin to that sort of implant shape. And Dr. Vega can insert the tissue into that, but it is not necessary to have tissue expanders placed in anticipation of a flap. Did that make sense?
Yeah, I would yes, that's perfect. I would say that when you're in my practice and we're doing that, it's because by doing that special type of tissue expander, you can create a beautiful breast mound that's conical and it has the nice dimensions to it. And then you can expand to the size of the flap. So then when you're putting the flap in, you can almost have the hidden incisions natural breast. Like,
Right.
now that's kind of a Cadillac reconstruction to do that. And I definitely, like I saw a patient today who she was expanded to about 400 or so, maybe 500 on her expanders, but her flap was going to be like 1100. So she's like, do you think I should expand more? And I said, well, if you want it cosmetically to not have more skin shown, right? The bigger paddle of skin from your belly, then we gotta fill you up more so that when I take that expander out and do your DIP, then you only have a little tiny piece of skin showing. And I would say it's mostly cosmetic in someone who really has the luxury of being able to get through those stages like that. It definitely takes time. Yeah.
Okay, I think we have 3 questions left, and I appreciate you all staying and hanging tight. Are there any surgical procedures to help release cording issues of the armpit area post mastectomy? I know that's something many people struggle with that we see at the coalition.
Can you
You wanna
repeat the
go for it?
question? I'm sorry, I missed it.
It's about cording.
Oh.
Surgical procedures to help release cording issues in the armpit area post mastectomy.
Rachel, do you have anything on that?
Sure. I mean, I would say that most people are able to work through the cording with physical therapy. The most important thing is that after mastectomy, you don't want your arms to remain static along your side. You know, I've heard a lot of people say, "Oh, I'm supposed to pretend like my shoulder is broken." No, if you pretend your shoulder is broken, that's probably a sure way to develop cording. So you want to try to maintain your range of motion. And start working with physical therapy pretty soon after the drains are out. So usually in our practice, we don't start physical therapy until the drains are out and we're sure that the fluid accumulation is not going to be, it's not going to come back. And then, within about 3 weeks after surgery, patients know if they're tight and if they're going to need physical therapy, and early intervention works. I know that sometimes when you go back for a second stage surgery, you can sometimes break up a little bit of the scar tissue, Steve.
Yeah, I was going to say it's very rare, but there are cases, probably mostly patients that have had radiation and the cording gets stuck as like a big fibrotic cord, where I've actually had to cut those in surgery to improve them. But that's rare. I would say I agree with Rachel 100%. It's mostly physical therapy and working through it.
Okay. And speaking of other muscular and mobility issues, somebody just dropped in the chat, is there a way to strengthen other abductor muscles if gracilis was used for replacement?
I mean, most people would say that you don't see any loss of strength with the gracilis. It's kind of an accessory muscle, kind of like the appendix and the abdomen. And there's at least 7 other muscles in that grade. So whatever adductor strengthening exercise there are, the big adductors are all maintained. The adductor magnus, adductor longus, there's a lot of redundancy there. So I would say just whatever other adductor exercise you normally would do.
And yeah, PT could probably help with that too.
I agree.
there was a question about nipple reconstruction from ear cartilage and whether that is something that you offer.
That all me, Rachel?
I know the answer to the question if you want me to answer it.
No, no, no. I mean, I'm happy to answer it. So I leave nipple reconstruction with ear cartilage to the rare event where I have somebody who, after trying to do the typical, I actually had a slide, I didn't include it, but I should have, the typical sort of flaps that we do to create a nipple areolar complex. When that is not projected enough or not big enough, then what I'll do is I'll actually take cartilage from the back of the ear with skin and put a composite graft. And for the patients that want that tactile sensation and to feel that something more projected is there, that works. I would say it's my last resort. I don't do it very often, but I do it. Is that right, Rachel?
I
That
think you
sounds
did one
right.
this year. One.
Yeah, right, one, exactly.
Okay, and I think I've gotten most everything, but there was a really good question about for anyone struggling to decide between DIEP, flap, or implants for exchange surgery. What are the top questions that you'd recommend asking any surgeon? And what are the top things that should ideally be considered? I figure we'll end on that one because
I'd like to hear Rachel's answer if she thinks she has one, because it's like a woman's perspective and somebody who kind of knows how it works, but then I could also try.
I was going to hold up my little sign that says,
There, that's mine too. Yeah.
goodness. All right. Well, I think for starters, you have to know that you have enough tissue to recreate the breasts. I feel like lots of our patients will come in and their immediate gut reaction is that they want to use their own tissue. And I always joke with them and I say, take your hands, cup your breast, and then cup your belly. And if the belly is bigger than the breast, then you may be in luck. Dr. Vega can make abdominal tissue come from some very slim patients, but in order to recreate two breasts, it really requires a lot of tissue. I think easier for him in one. I think the major considerations, the way I counsel patients is that if you're doing a unilateral mastectomy, again, I didn't focus on what this specific person was asking, but if you're trying to do a unilateral mastectomy, a flap is really a great choice because it will match the texture pretty closely to your natural breast. And so when you inset the abdominal tissue, usually most people will have enough for one breast, and then the hand feel, for lack of a better word, is the same. So I think that creates nice symmetry. Abdominal fat tends to grow and shrink with you, right? So if you gain weight, it'll get bigger. If you lose weight, it will get smaller. It does all of the things that a breast does. For a bilateral flap, I think it's just a little bit more complex in terms of the need for volume. And I feel like that's usually the hard stop for most patients is that Dr. Vega will have to tell them, well, you can make two breasts, but they're going to be quite small. And that's sometimes a hard stop. And then, having enough volume and then the recovery, which is a lot longer than implant reconstruction. So I always kind of joke around because in our office, everyone has their own quoted weeks of recovery. Dr. Vega will be like, oh, you'll be done in 2 weeks. You'll be great. You can go back to work. And, the nurse practitioners will say, that's more like 4 to 6 weeks. So I think that all the numbers are a little bit subjective, but I think the recovery from a flap is definitely longer and harder. But is worth it if you're looking, if that gives you what you want. A lot of it is personal choice, but I'll plug the PALS program because if someone is thinking about tissue reconstruction, you guys have a Rolodex of people who have gone through that experience. And I think that we also have a Rolodex in our office of patients who are willing to share their experience. So if that's something that you want to talk about, we're happy to share.
Yeah, that's perfect, actually. If anybody
That's a great
wants to
answer.
talk to somebody who has gone through multiple, we can connect people to multiple pals who have made different decisions and share their own experience and why they decided to do one over the other, and how did it go for them. I mean, it's always grounded in experience, and case by case basis, it depends, but having people to talk to that have traveled similar paths is always helpful.
I'll add just two little things to that. One is that if you have, I have a lot of patients, I've been doing this for a long time. If I have a patient who has a flap on one side and has an implant on the other, for whatever reason, they had, cancer again, they didn't have another donor site. There's never a patient that prefers the implant over the flap, which is a true statement and kind of like true throughout. So people like flaps. They like, and the flaps get better over time. Implants, not necessarily. The implants are getting much better. I think we're at the point now where implants are just doing better and looking better over time. The next caveat I'd say is if you have so much abdominal tissue that like when I look at you for the exchange, I'm thinking, oh, I'd love to take all of that extra tissue and make a couple breasts out of it, and your tummy's going to look fantastic. Then you should seriously consider you should. I'm joking kind of, but you really should consider it, because why not get rid of something you don't want, make a very nice natural breast instead of having implants? And anybody who says, well, they'll look and act the same, they just don't have enough experience. The flaps will be superior. The surgeon might be more tired and not want to do it, but definitely a really good option. Yeah, I know me.
Win-win.
Yeah,
I know.
speaking of tired,
That's the true answer.
this has
It's a
been
big surgery.
marathon. Thank you
Yes.
both for staying late, answering all these questions. We appreciate you immensely. This was illuminating. Thanks everybody for hanging tight. Pretty much everybody has stayed for the entire time. You're going to get lots of gratitude in the chat, I think. And yeah, please, everybody, you're going to get that survey so that you can give us more ideas in the future about things that you want us to have these webinars about. We really listen to that feedback. And wishing you all a wonderful evening. And thank you, Dr. Farkas. Thank you, Dr. Vega, for sharing so much with us. I learned a lot, and it was genuinely a lot of fun. Love talking to
Thank
you.
you.
Thank you.
Okay, take
Take
care.
care, everybody.
Bye.
Good night.
Bye-bye.